decide to skip class, which I shouldn't. Not saying, not judging. Okay. Some definitions. Electrolyte, we've seen, these are charged particles in solution that can conduct current. Obviously, that's the way that muscles contract, specifically the heart muscle, exchange of sodium and calcium for potassium during depolarization with a return to neutrality back in repolarization. A buffer is a substance that basically prevents larger changes in pH. So if there's the presence of an acidosis or an alkalosis, a buffer is something that will neutralize that and not make it as significant. You probably have heard of the Tums commercial. The Tums absorbs 20 times its weight in excess stomach acid. It's a buffer. It's something that's going to neutralize it so it doesn't make it as acidic or as basic. We're going to take that acid or base and break it into either being a strong acid or being a weak acid. Strong acids, when placed into solution, dissociate almost completely into the two individual ions. So if I take hydrochloric acid and I put it into solution, do like you oughta and add acid to water. Never add water to acid. It will be bad. It splashes back at you. But when I take hydrochloric acid and I put it into solution, the hydrogen ions and the chloride ions dissociate almost entirely. Those free hydrogen ions are what make it acidic. So a strong acid is one that dissociates completely. A weak acid, on the other hand, is one that dissociates to some extent, but not very much. So there's an example of that, as we'll find, is carbonic acid. Carbonic acid, H2CO3, stays as H2CO3 for the most part. There's a few of them that dissociate into bicarb and hydrogen ions, but otherwise they're pretty much together. Strong base, weak base, exactly the same as far as whether or not they dissociate completely or not. Here's a kind of just a slide showing different things that are acidic through basic on the bottom. Basicity, it just sounds wrong, right? How about alkalinity? And blood, you see, is slightly on the alkaline side of 7.0, where 7.0 is assumed to be a neutral pH distilled water. The degree to which it dissociates is basically what is known as the dissociation constant. And a bigger number means bigger dissociation, smaller number means smaller, and it's depicted by something called K sub A. Blah. All I want you to know is that we can quantify the degree to which something dissociates. Okay? On the top, we see our strong acid have a very high dissociation, that they separate into hydrogen ions and chloride ions, and only a small number are present as hydrochloric acid. So for the most part, they've dissociated into the two individual ions. Carbonic acid on the bottom is a weak acid. And being a weak acid, it dissociates only very little. Those free ions that are present, those hydrogen ions, they're kept at a very relative value within the body. As we'll find in a few minutes, there's a couple different ways that the body regulates the amount of hydrogen ions that are present, but it's through some mechanism to buffer them. It ties them up. Okay? The actual amount of hydrogen ions is an extremely small number, 10 to the minus 7 mole per liter. So it's a negligible thing. So we express it, instead of measuring it in its actual quantity, we take the logarithm of it, because the logarithmic scale is an exponential scale, and it can be expressed a whole lot easier. We also are looking at this as far as the negative logarithm of the hydrogen ion concentration. So as the hydrogen ion concentration goes up, the pH actually goes down. Let me say that again. As the concentration of hydrogen ions gets larger, this doesn't want to work with me today. As the hydrogen ions go up, the pH goes down. And we would say it's more acidic. So there's an indirect relationship between hydrogen ions and pH. The normal value for pH is 7.35 to 7.45. Another value that you'll need to memorize, because we're going to use this quite extensively. The way that it is maintained at a normal level, it's a very small range of pH. And the body does a fabulous job of keeping it normally within that range. 3 ways it does it. There are some buffers within the blood and within certain tissues that neutralize the number of hydrogen ions. This is almost instantaneous. There is also the respiratory system. We can control acid-base balance by hyperventilation or hypoventilation, as we'll see in a minute. That takes minutes. And finally, we can have the kidneys regulate the amount of hydrogen ions or bicarbonate ions, but that takes days. So instantaneously, we have buffers within the bloodstream, within the tissues that neutralize the excess amount of hydrogen ions or shortage of hydrogen ions. We have the respiratory system compensating, and we have the renal system compensating. Hoping that was going to work. For right now, just know that there's buffers that are out there. I don't expect you to know what the names of them are. I just put them there because eventually we will, but for right now, don't worry about it. One of the buffers, if you notice, is hemoglobin. And if you go back and you look at that picture where it had how CO2 is transported, one of the things that hemoglobin does is it picks up the excess amount of hydrogen ions. As CO2 moved into the erythrocyte, carbonic anhydrase was there. It formed carbonic acid dissociated into hydrogen ions and bicarbonate ions. The bicarbonate ions moved back into the plasma through the chloride shift. The hydrogen ions then are buffered by hemoglobin. And you're all saying to me, Rick, that was so long ago. It was like last week. Can't possibly expect us to remember that. But there's buffers. The relationship as far as the quantity of bicarbonate ions and carbonic acid that is present is described by the Henderson-Hasselbalch Equation. And no, you will not need to memorize or ever calculate this. The primary reason is there's something called a log function. And I'm making the guess you don't have a log function on your calculator. Pretty safe bet, I would say. There is a relationship between how much of this is present and how much of this is present. And if you look at a normal situation at a pH of 7.4, midpoint of the range, there's a ratio of 20 to 1. we remember back to our hydrolysis equation, right? Vaguely remember this? There is a relationship between CO2 and carbonic acid that we can really substitute one for the other. If CO2 rises, the carbonic acid level rises. They're a direct relationship. They're proportional to each other. And as you put more CO2 into the system, you create more carbonic acid. It's a given. Okay? So I'm going to just make that as a relationship. And if you go back, we actually said if I take my carbon dioxide level, my PCO2, multiply it times 0.03, I basically end up having this carbonic acid level. And that was back a few pages probably. So taking a look at my equation here that we're going to ignore because it's painful. Carbonic acid concentration bicarbonate concentration to carbonic acid concentration. Normal bicarb is 22 to 26, midpoint of 24. Normal PaCO2, 35 to 45, midpoint of 40. Take that 40, multiply it by that 0.03, and I end up with 1.2. 24 divided by 1.2, 20. There's my 20 to 1 ratio. I then determine the log of that, add it to this thing called pK, and I end up with a pH of 7.4, normal pH. Make life simple. We can just say that pH is related to the bicarbonate concentration divided by the PCO2. Or stated another way, bicarb is regulated by the kidney, PCO2 is regulated by the lung. So those two organs are critical for acid-base balance. That's the way we're going to regulate the pH level within the body, either through the kidney or through the lung. pH, 7.35 to 7.45. That's the normal range. Gets above 7.45, we're going to call it alkaline, or alkalosis is the condition. Less than 7.35, we're going to say is an acidic or an acidosis. PaCO2, 35 to 45. Greater than 45, I say that it's alveolar hypoventilation. Less than 35, it's hyperventilation. PO2, we said normal range was 80 to 100. Well, I'm going to throw a monkey wrench in there. You don't need to know the rough estimate, but just in case you're wondering, as we age, one of the downsides, we start losing functioning alveoli, our PaO2 falls. Just kind of a natural tendency. However, a value greater than 100, greater than normal, we're going to call hyperoxemia. Hypoxemia, we're going to break into 3 levels. Between 60 and 80, we're going to call it mild. 1679, technically. Between 40 and 60, it's moderate. Less than 40, severe. Now, I will tell you, every time I test people on this, there's always one or two people in the class that insist on putting moderate as being, they switch moderate and mild. And I have no idea why. It just boggles me. Why would moderate be better than mild? Mild is 60 to 80, moderate is 40 to 60. Severe is less than 40. And we know the saturation, we know the bicarb. Okay? So pretty much all of this we've had previously, except for the staging of the hypoxemia. Because by the end of the day, the hope is you'll be able to look at a blood gas and say, oh, that's a partially compensated respiratory alkalosis with mild hypoxemia. That's where we're heading. All right. So let's talk about this relationship of bicarbonate ions to carbonic acid ions. That ratio is normally 20 to 1. If the ratio goes up, we're going to say that there's an alkalosis present. That ratio can go up because the numerator went up or the denominator went down. Let me say that again. You can create an alkalosis because either the numerator goes up, the bicarbonate level rises, or the denominator goes down. There's excess carbonic acid, I'm sorry, there's a reduction in carbonic acid or PCO2. We say the same thing because they mean the same thing. So there's a reason that alkalosis can be created that is a respiratory issue or a non-respiratory, or what we're going to call a metabolic. I can have a situation where, for whatever reason, the bicarbonate level within the bloodstream rises, and I have an alkalosis that is created that I'm going to call a metabolic alkalosis. I can have a situation where the PCO2 falls, hyperventilation is present, PCO2 falls, the ratio gets larger, and I have a respiratory alkalosis. This will probably occur about 10:30 today, as we're hyperventilating prior to the next test. Does that make sense? Because this becomes very critical. Hearing no arguments, I'll go on. If for some reason that ratio falls, an acidosis is created. Ratios that are smaller than 20 to 1 are an acidosis, and that can be caused by either a reduction in the numerator or an increase in the denominator. Either the bicarbonate level falls or the PCO2 level rises. Am I going too slow? Okay. So I need to take a look at a blood gas, and I need to classify it. First step is always to take a look at the pH. Less than 735, acidosis. Greater than 745, alkalosis. Between 735 and 745, normal. So if I said my pH was 7.16, what do I have? Acidosis. Is it a respiratory acidosis or a metabolic? I don't know. All I know is that I have an acidosis. 7.6. That's an alkalosis. Okay. It's the easy first step. Okay. Step 2 is to figure out who's causing it. There are 4 primary disturbances that are present. 2 that are caused by a respiratory problem, respiratory acidosis, respiratory alkalosis. 2 that are caused by a non-respiratory or metabolic disturbance, metabolic alkalosis, metabolic acidosis. It's got to fit into one of the 4 boxes. Actually, technically, no, because I can have 2 processes going on simultaneously, what we call a mixed problem. But for right now, we're not going to worry about mixed problems, because that's just plain mean. I'll let Jeannie do that next year. Okay? So let's talk about these individually. First one, respiratory acidosis. Acidosis implies that the ratio is less than 20 to 1. The denominator has gotten larger. This is where the PCO2 is being increased, meaning that I have hypoventilation present. I do not want you to worry about knowing what the causes are for now. Okay? However, it's something where either the brain is not sending an impulse out, maybe head trauma, barbiturate overdose. There's a neuromuscular disease, and Jeannie will spend some time talking about them next semester. Myasthenia gravis, Guillain-Barré, muscular dystrophy, polio. Oh, and it's raining in Columbiaville, just for those of you who care. There's muscle fatigue that is present either from resistance going up or compliance going down. Okay. But there's a problem there someplace. So you don't need to really know these. You can skip over that. If the body sees an acidosis and it's caused by the respiratory system, it's going to try and balance that, correct that, compensate for that by creating the opposite situation. If I have a respiratory acidosis, the body attempts to create a metabolic alkalosis. So it uses the other system to go in the opposite direction. Think of it as a scale. If one side tips, respiratory acidosis, the body is going to try to tip it the opposite way to get it back to a normalized pH. So it needs to increase the number of bicarbonate ions to make that ratio back to 20 to 1. Increase the PCO2, ratio tips below 20 to 1. The body attempts to retain bicarbonate ions, increase the numerator to bring that ratio back towards 20 to 1. Okay. So the kidneys now have to kick in and retain bicarbonate ions. What did I say earlier, not that you were, focusing on this? How long does it take for the kidneys to work? Days. So in the acute situation, we ain't got time to wait. We're going to intubate and ventilate that patient. "18-year-old comes in, found near bedside, empty bottle of barbiturates and a fifth of Jack Daniels, half gone. Breathing at a rate of 6 times a minute. Not a good scene. We don't have time to wait for her acid base to be corrected by her kidneys. We got to intubate and ventilate. Make sense? Okay. Here is the situation when she first comes into the ER, what we end up seeing. We have an acidosis. Who's causing the acidosis? It's a respiratory. Why? Because the CO2 is increased above normal range. What about the bicarb? It's a normal bicarb, isn't it? So we would call this an uncompensated respiratory acidosis. Why? Because the kidneys haven't attempted to kick in. There hasn't been time. Acidosis, who's causing it? The PCO2 rising, or a respiratory acidosis, and the kidneys have done nothing. They're asleep at the wheel.
If the bicarbonate levels were higher, it would...
You got it. Which is our next slide. We're going to call this compensation uncompensated, meaning nothing, partially compensated, which means the thing that's supposed to be doing the compensation has started to work. It's outside normal range, but our pH is not back to normal. It's trying. It just isn't all the way there yet. If the pH returns back to normal, then it's fully compensated. There's no such thing as overcompensation. And we'll spend some time next fall talking about all the bizarre stuff that can end up happening. Unfortunately, people rarely come in with just one solitary problem, especially the elderly. They often have comorbidities, as a word. There's multiple things wrong with them. But we won't worry about that yet. So, the compensatory thing for a respiratory acidosis is to retain bicarbonate ions. It's going to do this either it's not going to do it at all, uncompensated. It's going to rise above its normal level of 26 milliequivalents per liter, meaning it's attempting to compensate, but it's not quite there yet. The pH is not back to 7.4, or 7.35, I should say. Or it's all the way back and the pH is back to within normal range. So here's an example of a partially compensated respiratory acidosis. pH, what is it, 7.2? Acidosis. What causes an acidosis? The rise in PCO2 or the rise in bicarbonate? Well, the rise in PCO2 does. The body then begins compensating by retaining bicarbonate ions to try to bring the pH back towards 7.4. It's trying, but my pH still isn't back to normal. So it's a partially compensated respiratory acidosis. The bottom blood gas, my pH now is returned back to normal. It's finally got around to fully compensating. So if I were to look at that blood gas, I would say that's a fully compensated respiratory acidosis. Second disturbance. And I'm going to go through these a little bit quicker because the process is the same. And once you get the hang of it, it'll be a whole lot easier for you. Respiratory alkalosis is caused. Alkalosis means that the ratio is greater than 20 to 1, and that implies that the denominator has gone down. The respiratory component, the PCO2, has been reduced due to hyperventilation. Again, you don't need to worry about the causes, but the most common one is the last one, Somebody who's hypoxemic, what does the body do for hypoxemia? Increase the heart rate, increase the respiratory rate to try to compensate. So they actually overventilate, trying to bring more air in to get more oxygen in. Compensatory respiratory alkalosis, it's got to be a metabolic acidosis. How does the body create a metabolic acidosis? It dumps bicarbonate levels, but it takes time. pH elevated, alkalosis. Who's causing it? The PCO2 being low. There's an uncompensated respiratory alkalosis. Again, with compensation, partial full, partially compensated, the bicarbonate level is moved outside of its normal range. And now we have an attempt to try and correct for it. So the pH is still not back to 7.4, but the bicarbonate level has attempted to drop to compensate. Partially compensated respiratory alkalosis. And finally, pH returns to normal. Do we see where this is going, guys? Maybe or maybe not. Two other ones. Metabolic problems. Again, we can have an acidosis or an alkalosis. Metabolic acidosis is where bicarbonate levels, the numerator has gone down. Ratio is less than 20 to 1. And we'll find there's all kinds of reasons why. What is salicylate? Somebody know? Salicylate overdose? Acetylsalicylic acid, ASA. What is it? It's aspirin. It's a fancy name for an aspirin overdose. If I have a metabolic acidosis, the body attempts to correct for it by creating the opposite. Alkalosis, respiratory alkalosis. The body attempts to hyperventilate. Think about Kussmaul's breathing. Rapid and deep. It's an attempt to move lots of gas in and out of the airways. It creates that respiratory alkalosis to compensate for a metabolic acidosis. Here's an acidosis, 7.3. A PCO2 that's 40 would not cause it, but a bicarb of 12 would. And by the way, that's an uncompensated uncompensated metabolic acidosis. The first blood gas there is a partially compensated. The CO2 is moved outside its normal range to try and compensate, but it's not quite there. The bottom one is a fully compensated metabolic acidosis. And then finally, we have the metabolic alkalemia, and I won't spend a lot of time on this because it's the same exact thing. And we end up seeing elevated pH, elevated bicarb. The elevation in the bicarbonate is the thing that causes the alkalosis. Ratio gets greater than 20 to 1. And then we slowly have the PCO2 rising because the patient hypoventilates as a compensation until finally they're fully compensated. All right. The only way to get good at this is to practice. Okay? On my website, I have a random generator. This is actually, in fact, let me do this. Let me pause it here.